But for this group, I think it's important to do so. And I think there's, some of you may understand completely what I'm saying, and I may be dispelling some myths. First of all, at your level, there is no such thing as a minor gunshot wound. There is not. There is not. There is not. We can have gunshot wounds that are very apparent, and we can have gunshot wounds that are not very apparent. And I know that the thing today is, you know what, bigger is better, so I want my 45 so I can knock this guy. No, I'm going to get a 50 so I can knock that guy. I believe in my heart, based on my experience, especially in Vietnam, that the concept of using a handgun to knock someone off their feet is a myth. Doesn't happen.
Movies.
Pardon me?
It's a movie.
It's a movie. It doesn't happen. It has to take time for them to lose blood, unless they're, of course, hit in the head. So we have to distinguish the high velocity and the low velocity. In my opinion, the most dangerous gun that anybody can be exposed to is a .22.
Correct.
Because a damn .22 will, you never know what the hell it's going to do. Oh gosh, I've seen people who got it hit here and they pulled it out of the left ventricle of their heart and they were deader than hell. They hit, I've taken care of it. I know you've read the stories, but I took care of the guys. When organized crime was a gentleman's game and not a drive-by spray the shooting. It was 122 to the ear, and oftentimes you couldn't even see the blood, but they were deader than hell. The idea is, once these bullets hit the body, they move around. And it's not just the bullets that we've got to worry about, it's the bone fragments. Some would argue that while it's more catastrophic to deal with a traumatic amputation secondary to a blast injury, it's easier to manage than a penetrating injury to the torso. At least I can control bleeding from the femoral artery. I can't do a damn thing if I'm bleeding out from my liver. I can't do anything if I'm bleeding out from my aorta. I can't do anything. And the problem is, oftentimes, the blood that's going to cost them their life is not the blood that you see. It's all inside. So, one of the things that I would like to elaborate on, and then I'd like comment from Tom and from all the ER folks. It's imperative to get them to the hospital as soon as possible. It's imperative to put pressure and get them to the hospital as soon as possible. There's a reason Detroit cops, when one of their own is hit, do not wait for an ambulance.
This is true.
That's absolutely true. They're in the back of the car, somebody's got pressure, and because I'm going to tell you something, with a torso wound, I in an ambulance can't do one damn thing more than you can do. All I can do is put pressure on it and try and get them to the hospital. Because somebody's got to get in there and stop that bleeding. And we call that, nowadays, the golden hour. And we're getting pretty good at it. And we'll stay good at it if we take the lessons we learned the hard way from Afghanistan and we live by them. So many lessons we learned in Vietnam, they decided later on, well, that's such a bad idea, we won't do it anymore. Then we went back to Afghanistan and had to learn it all over again. Because some very smart people who had very long initials after their names decided that their clinical trials were contrary. I'll never forget. Can I tell this story?
Sure.
The head of the emergency department at University of Michigan. We used to have a device, and I know it's out of vogue now, but they worked. We used to have a device that was called mass trousers. They were military anti-shock trousers. You put them on, blew them up, and it pushed all the blood up to the chest. Now, it didn't save anybody's life, but it bought you some time. Got you some time. I've seen people that were unconscious, we blow them up and they get... So I had a patient that exsanguinated one time, and the head of the ER at University of Michigan, I was always kind of vocal because I wanted progression. You know.
Shocking.
Shocking.
10,000-yard stare.
So I said to him, you know, we've got to get IV therapy, and this was before we had it. We've got to get IV therapy in this county, and we've got to get mass trousers. And he said, well, we haven't proven the effect of those treatments. And I said, excuse me, Dr. Bernie, I thought we learned that in Vietnam 10 years ago. He looked at me and he said, John, this is Washtenaw County, not Vietnam. And I said, Dr. Bernie, I didn't know people bled differently in Vietnam than they bleed in Washtenaw County. So,
He didn't take you to lunch that day.
actually, he and I were pretty good friends, really. The point being, you want to get him to the hospital. I mean, and I'm probably going to get shot for saying this, you know? Somebody's going to find offense to what I've said. If one of you, if I were here, and one of you took a gunshot wound to anywhere in the torso, I would be trying to haul your ass in the back of a car and I'd be heading for hell. I would not be waiting for time for that ambulance because I can't put the blood back that I lost waiting for the damned ambulance. Now, there are people here that are going to disagree with that, and I appreciate that. But I would have no problem in this world if somebody was injured here, going in the back of the car and getting there. Some people say, well, what about the liability? I'd rather have the liability of dealing with a live patient than a dead one. So, questions about gunshot wounds? Comments from, say what you got to say, boy.
So, as you were saying, they learned a lot of lessons in Vietnam and then they forgot them. Well, luckily nowadays, the civilian medical community is paying attention. It's taking a while, but they're learning from what the military has learned in Iraq and Afghanistan, and they're applying it to their new trauma techniques. That is why the tourniquet has come back into civilian use. It was gone for a very long time. It's back now because the U.S. military has shown that it saves lives. It takes a while. I was talking to a couple guys saying it takes about 5 to 10 years of something that the military does now to get to civilian emergency medicine, but it gets there and they're paying attention. So they have a new piece of equipment. It's basically an abdominal tourniquet. It goes around the waist. Brand new piece of equipment being used in Afghanistan. Wouldn't be surprised if we see it within the next few years in emergency medicine.
Tom, have you had an opportunity to see the literature on that syringe where they insert the many, there are many, many pieces of gauze, microscopic pieces of
Oh yeah.
They're coming up with some good.
What about quick clot? Is that stuff any good?
There are so many different types of quick clot. We could talk about it for a very long time. The first stuff they invented, it was a powder, and instead of absorbing the blood like the stuff does now, it used to cauterize the wound. It used to heat up really hot and dry out all the blood and cauterize the wound shut. They proved it was doing more harm to patients than good, so they phased that out. Now we use something called combat gauze. It's this stuff. It's a roll of gauze that's been impregnated with an agent that actually helps the blood coagulate faster. It works really well. I've used it personally. It's just really expensive at the moment. I don't know if it's in civilian medicine. I know it's not in Michigan at the moment, but I'm sure it'll come eventually.
Well, it's not in pre-hospital, but it is in the hospital.
In the hospital.
We have a doctor at the University of Michigan who's doing research for one company. Do you know who that is?
I don't know the company.
Do you know who the doctor is?
You can find that online.
I'm sure you can. It's quick clot combat gauze.
Just Google clotting agents.
You can, some of those you can find in the Army Navy.
The powdered stuff, I wouldn't touch it.
You might. I don't know.
No, I've seen them.
It's no good.
You seen them?
Yeah.
So he's saying at the Army Navy store they've got them now.
Do they?
The sheriff?
Yeah.
Which
Now-
one are you saying is no good?
The powder, don't use the powder. They used it from probably 2003 until about 2006, and then the military got rid of it. There's better stuff to use now. I would just throw it away if you had it. It's not worth the time.
Yeah, it comes like
They
the
do.
same package.
They- They do have some stuff that they are using now. Up until recently, using it in an abdominal or chest wound would have been counterindicated. But that's what they're doing the research on now. As to whether, how far they are with that, I don't know. But I thought they were going to get some for here, some of the, but I didn't see it there. So I don't know, Bob, if they got it. Again,
We'll follow up on that.
You said,
you know, again, a good cravat tied tight. John, do you have any comments?
No, but I would agree with you about the 22. And I've seen people shot in the arm and it rolled right into their heart.
He was talking a while ago about doctors, you know, sometimes they don't want to listen to you. I had a gal one time in Ypsilanti that was shot here in the collarbone, and she was complaining about pain in her wrist, so I took her into St. Joe, and I had to go do something else, and I came back. Of course, there was no exit wound, and it was a small caliber, it was 32. And I came back sometime later, and I asked the doc, I said, so where'd that bullet end up? He said, you're not going to believe it. I said, believe what? He said, that bullet went in, hit the clavicle, and bounced back out again. That is an entry-exit wound. I said, what? He said, we x-rayed up everything up here, there's nothing there. I said, you better keep looking, because that bullet's there. And they found it down in her wrist. That's the reason her wrist was hurting. They will go everywhere. Everywhere.
In my experience in Afghanistan, we were fighting against guys using Kalashnikovs, big 7.62 rounds. They cause less damage than what we use in the U.S. military, the 5.56 round. It's a lot smaller, a lot less weight. It'll hit a bone and it'll bounce all over the place. It's
designed to do what?
It's designed to do that, but smaller civilian rounds like 22 caliber, 38, they'll do the same thing. They're much more dangerous than the larger rounds. The larger rounds have that momentum, and they'll keep on going through. Where the smaller rounds will hit a bone or something semi-solid, and they'll deflect all over the place.
This is you know, one of the things that I've done in my career is I used to work with the sheriff's department. I trained the sheriff's department in their first aid and so on. I did a lot of talks on ballistics and gunshot injuries and so on and so forth. And there was a case in California that several years ago that I think makes another point. There's another point to be made, and that is, in this day and age, you may be facing an adversary who shoots you. Never recognize the fact that you're shot. Don't think that you're shot. Don't just lay down and give up. We had a 24-year-old California highway patrolman, a female, in 1986. I'll never forget it. She was approached by a suspect or confronted a suspect. He had a .22 and he shot her. She felt the bullet hit her chest and she fell to the ground. The round actually hit her badge and it did not penetrate her badge. But she was convinced that she was down, and he walked up and put another one on her head. So bullet wounds are not, their actions are not instantaneous. Just because you've got one doesn't mean that you're defenseless. And if you do see someone with one, you want to get them to expert help. And most of the help that's done for gunshot victims is done in surgery by the surgeons. There's just not a lot the rest of us can do for you.
It does take a while. I had a soldier that I worked with, he got shot, and we went through the entire firefight, about 30 minutes. He kept fighting, and then afterwards he came up and said, hey, I think I've been shot. And I checked him out and he had been. It takes that long for stuff like that to take effect.
Our record in Vietnam, which we were fighting the AKs. Our record in Vietnam, we had a 101st Airborne guy. He was a big guy, he was over 6 foot. When they finally pulled him away from the tree to carry him down to the aid station, he was still on his feet, he was still fighting. He'd been hit 26 times. Still on his feet, still returning fire. So that's a mentality. The NRA talks a little bit about that in their CPL class. You've got to have a mindset of never giving up, never quitting. if you're gonna survive. And you never know what's gonna happen if you just hang in there. Just hang in there. Pardon me?
That guy survived?
He did. He did survive. I don't know how long after the war he survived. You know, some of those guys with those bad wounds, they lived a few years and then died from complications, but he survived that episode.
Shame I saw, I can't remember his name, almost survived.
Yeah. One of the other things that we talked about we were going to do